We will go ahead and get started today on the Quality and Patient Safety Committee. We will go ahead and call to order. It does not appear that there are any citizens who are wishing to address the committee today. All right, so we will go ahead and we have to make approval of the previous minutes. Can I get a motion to approve the minutes from the previous meeting?
Motion to approve with one amendment,
Okay.
which Lonnie knows, to add me to the attendee list. That I move to approve.
Okay. Can we add Blake to the attendance? Okay.
Do we have to second that? No.
Can I get a second? All right. Any opposed to approving the minutes? Okay. All in favor, say aye.
All right.
Okay. So the minutes have been approved. All right. Today we're going to have Dr. Assad is going to present for us today. We always start these with a patient voice just to kind of center ourselves and just refocus on the reason why we do this, why we're here.
Thank you very much. It's really my privilege to present instead of Dr. B. I hope I can do some justice to what he does. I will give it my best shot. So today we are going to share a video of a patient who got a procedure done which was approved by the board last year. I think it's extremely important to hear. Sometimes the board approves things and we may not get to see what was the outcome of it. I think this video will highlight that what you guys approved in January last year of 2025, it changed a patient's life. And if it changed the life of one patient, you can just imagine that what it is doing and will be doing for all the others. This is a TAVR procedure, and I will briefly tell you that this is an extremely important procedure, especially in patients who cannot get open heart surgeries. It's a minimally invasive procedure which allows the patients who are not candidates for open heart surgery to get this done and get back to doing what they most enjoy doing. So let's watch the video.
What brought me to JPS is the doctors. I hear that they're some of the best doctors there is. And the care team is what I remember the most because they were really there before and after. My name is Cheryl Renita Hogan. I'm 70 years old. I'm an author. Every day I was in the hospital, because I could not breathe. And they couldn't understand why I was not breathing. They took x-rays and all of that. And then I went to the cardiologist. And he said, "You have a heart murmur." And he said, "I'm going to send you to a doctor. And he's going to tell you about a procedure named the TAVR."
So the TAVR procedure is designed for people with aortic stenosis. This is where the main valve of the heart, through which the heart pumps blood to the rest of the body, gets narrowed. And this tends to occur more frequently as people age because this is a degenerative process. And the symptoms of it can be rather insidious. They come on slowly. And people see this drop in exercise capacity. They're just a little bit more tired. They're not able to do the things they used to be able to do. It was much advantageous for us to do this catheter-based procedure because it was going to give her the best chance of a quick recovery.
And that was it. I said, okay, let's do it. Because I wanted to feel better. Oh, do I feel better, girl? Yes, ma'am. Yes, ma'am, I do. It's easy to breathe. It's like being on the slopes, where the air is cool you know, and it's running through you. I mean, that's what it's like all the time.
You know, seeing these patients before and after their procedure, a lot of them had changes in what they were able to do throughout their life. You know, patients that have worked in fields, doing very physical labor. And then afterwards, you know, the patients and their families have told me how much that has changed their life. They've been able to get back out there doing what they were doing before.
Since the TARBA, I have been able to do so much. You know, like I said, I couldn't take 4 steps without being out of breath before the TARBA. And now I take my little Tchd, you know, and walk her down the street, take her to the park, walk around a little bit, let her run around. It's not hard.
I think that our team puts in a great effort to bring this program, and when they hear these beautiful results, they are excited. They have been excited to see the results in all these patients that we have done. We're very grateful that this is something that we can provide to patients here.
My care team, girl, they were always right there helping me get through it, helping me not to be afraid. You know, we're gonna find this vein in your arm, you know, you're gonna be all right, you know, and everything just went as it should have gone, you know, just smooth.
I think that's what we live for as doctors, and as a whole team, this motivates all of us. I mean, to hear that from Mrs. Hogan, that she has such a great experience, makes it all worth it.
I think what is very telling is what Dr. Lokhandwala said. This is what motivates us. I think us as providers, things like this truly motivate us. All right, with that, we are going to move on to our Vizient clinical database. This is kind of almost like a sneak peek preview into what we are going to be, which Dr. Bedamosi is going to be moving on sharing with you. Vizient clinical database, some of you may be aware of it. Those who are not, it is actually a healthcare performance improvement tool, and we partnered with them. It's going to go live for us in March. What it allows us to do is it allows us to do benchmarking with our peers. It allows risk standardization. It allows us to understand what are the gaps with safety, quality, utilization. And after you're able to identify those gaps and all the way down to a provider level, you are then able to actually have some financial, you can identify the financial impact if you were able to rectify those gaps. I think it's important to see that we're not the only one who have actually partnered with an organization like this. There are 120 healthcare systems across US, just naming a few: Mayo, BGC, Mass General, and Beaumont. And then 98% academic medical centers have partnered, and over 1,000 academic and community hospitals. So we are not unique. People are already doing this. And as I already said, it allows you to benchmark. Currently, we do not have the ability to benchmark. And you will see, I think the next slide kind of alludes more that you can slice and dice it in whichever way you want. And I think that's the important thing. Sometimes you get compared to hospitals which are not like yourself, and that then creates a lot of questions. It allows you risk adjustment, because you want to really compare two things which have like apples to apples, not apples to oranges. And then I think the other thing which is very important, this is across the network. It will go into the ambulatory setting, the inpatient setting, and it goes all the way to the provider level. And I think which is, from a provider aspect, it's extremely important to know what your peers are doing. And once we are able to identify the gaps with safety, quality, utilization, you're able to rectify them. And I will also say one more benefit is it is real time. There is not a lag. Like sometimes you see data coming from CMS and there is a lag, and different metrics have different kind of lag. This allows you to act more in real time, rectify those gaps, understand where you stand with your peers, make it more meaningful at a provider level, and of course that brings financial impact. The thing which is most important, at least I'm sure that for a lot of people, we want to be able to slice and dice as we want. There are about 26 safety net hospitals that are in this data bank. Parkland, Grady, Cooks, University Health San Antonio. So again, it will allow us, it will actually give us a real leverage so we can do things in a timely fashion, so we can actually be more compliant with CMS programs and other entities like that. And I think from a provider level, every time you see a pair comparison, it drives you to do even better. So I think this was just more like a sneak peek that why did we actually choose this? What added advantage it will give us. But Dr. Bedamosi is going to share more, I think, in the second quarter, these reports. So I think this is extremely relevant for us and will give us a lot of leverage.
Is it just a quality, or are we using it for any other?
It is actually even for purchasing, and I know Charlie Cobb uses it. All right. Any questions before I go on to culture safety results? All right, this is a survey which is deployed every year alongside our clinician engagement and employee engagement survey. And we have shared it even last year, the results. This was deployed, let's go on to the next screen. It was deployed, it's usually open for about 2 weeks period. It was deployed in August. We had amazing participation, and this culture of safety is not unique to clinicians. This is across the network for all employees. And so there was a participation of 97%, which is amazing in itself. We have about 5,900 employees who responded. Our score was at 85th percentile, which is a very impressive score. And the actual score in itself, the raw score, was 4.17. There were 4 sub-indices which were looked at: critical information flow, culture management and policy, error info and remediation, and teamwork. If you notice, and I will go into the next slide, other than the critical information flow, we actually improved on all other domains. The 2 domains which actually require some more, which have an opportunity for improvement, is anytime there is an information flow between units or at shift time change, which should not come as a surprise. Anytime you're actually, these are high risk situations. Anytime a shift is changing or a patient is moving from ICU to OR or progressive care floor to a med-surg floor. So we are very acutely aware, and obviously that is a focus of our focus area where we want to do even better. So Dr. Bedamosi has worked with a lot of providers, and we have created a handoff tool. It is already live in ICU. And the hospitalist team, and the next stop is the surgical team. And what it does is anything which is outstanding, if it's imaging, if it's lab, it actually identifies that these are the things which are still outstanding. I think that's a very good way in which you can do a very safe handoff, and whoever is going to take over the patient knows, okay, for this particular patient, these are the things which are outstanding, and we need to keep a watch out for these. We are leveraging our IT, we are working with our nursing and all the providers, but again, it is still in the process of being rolled out. And I think this is going to, again, help us improve on these scores. Questions? Overall, we've done very good, 85th percentile.
Is that an Epic tool that you're talking about, the handoff?
Yes, it's a homegrown tool we've created.
Okay, so when the new, like say they go from the ER to the ICU, who then can see the handoff? Like who can see those?
The providers, the nursing at this point cannot, but the providers can. But again, Dr. Bedamosi is trying to fold in all the other services, and it's not yet rolled out across the hospital. It's right now, it is as far as the one is the unit and the other is the shift change. As far as the shift change, it's been rolled out to the hospitalist, the ICU, the next is surgery. But again, this is going to get broadened. All right, going on to our quality priorities. First is, as we, in our AIP goal, the first one is our patient experience scores. The dark bar is fiscal year 2025, and the light blue one is the fiscal year 2026. I will draw your attention to the upper left corner, which says that these scores are up until January 5th of 2026. We do have right now a stretch of 81.9%. It is a high bar indeed, but a challenge which we are definitely up for, and a lot of work George and his team is doing across the network, inpatient, ambulatory and our ambulatory surgical center. As you can see, we are doing well on all the domains, and we will keep working hard. But this is definitely a high bar. All right. Next, if you remember that we selected a quality composite. Just as a refresher, we have about four metrics that actually make this quality composite, and they each have an assigned points at the top threshold. You reach, it's 1 point, target it's 2, and stretch it's 3. At this point, on the far right column, you can see what our performance is. At this point, our performance for these 4 metrics is 3, and we are doing very well in C-section, and Dr. Carson Henderson and her team has done amazing work. Cannot say enough good things about the work her team is doing. They have leveraged technology, they have leveraged teamwork, they have truly shown what it does when the nursing and the clinicians lock hands and do something. So great work over there, but that doesn't mean that all is lost for all the other 3 metrics. Readmission is definitely a challenging metric. We have done a lot of work towards looking at what truly actually drives readmission. When you look at the CMS measure, we are actually doing very well, but this is all payer, all cause 30-day readmission. And the problem is that anytime, the biggest correlation is anytime your discharges go up, your readmissions go up. We are also at this point, so far we have a lot of initiatives that are going on. We have a team actually which meets every single day, and the patients who are at a high risk of readmission, there's a multidisciplinary team which gets together and figures out what are the best resources this patient should be discharged at, because what research has shown that the single thing, this is not isolated things don't work. Nurse intervention alone does not work. Just post-discharge planning alone does not work. It is actually a combination of multiple things which, if done correctly, before and at the time of discharge and post-discharge, actually yields some dividends. So we are currently, there's a team that meets to make sure that all of the things that would work for a patient is being discharged at. But we are right now taking a different stab at readmission. We are working with our research team to develop a homegrown predictive readmission model, so we can actually identify, based on every patient who's admitted, who is at a high risk of readmission, so that our approach kind of changes from the mentality of, okay, this patient was readmitted, so has a higher chance of readmission, to any patient, readmitted or not, what is the risk of getting readmitted? So shifting from really the endpoint to a predictive model. So a lot more to come with that. Third metric is the PSI 90. The problem with PSI 90 is it's a combination of a lot of metrics. And there are certain metrics that are weighted very high, like post-op respiratory failure, weighted high. If there is 1 or 2 fallouts, it's really going to make the score look pretty, that something is not going well. The reality is PSI 90 kind of evens out with the rest of the year performance. So again, a lot of work is going on. I know Dr. Webb and all the surgeons are heavily involved in this PSI 90 and action planning on any time there is a fallout. This blood pressure control in hypertension, this was a newly added measure, because when we looked at all our, across the network, our #1 diagnosis, at least, especially from the ambulatory side, is hypertension. And right now, we're not very far off. We are, I think, performing 77 to 78%, and our stretch is, if I can see correctly, is about 80%. There's a lot of work actually going on leveraging the EMR to form a clinical decision tool. Dr. Bedamosi is working right now with our ambulatory providers to leverage that tool so that we can actually provide this metric can show some improvement. Also for our learners with the residents, we are setting up some educational program also to drive this metric. So a lot of work in progress, and I think we're going to start seeing that this composite quality score is going to come up.
Now, is that the hypertension, is that in any clinical setting? So even if they're in the dental clinic or if they're in the surgical clinic, if it's a high blood pressure, it counts towards this? Or is it just in the primary care clinics?
I definitely know it is in the primary care clinic. I hate to give incorrect information. Dr. Webb, do you? Okay, yes, I think it is only in the ambulatory setting, but I can definitely take this back and find out if there is anyone other than ambulatory included.
So I want to say this is don't quote me on this. I feel like if it's in any ambulatory setting, it counts against you as far as the STARS metrics go. So it's just one thing to be considerate of if they show up at the surgical clinic and their blood pressure's high, that they need to make sure that they're getting back in with the primary care clinic to address the high blood pressure. So it might be a way for all of the ambulatory clinics to kind of work together on that.
And Dr. Holland, I'll get back to you as to is it just in our primary care setting or is it across the board?
When it's picked up in our clinic, yeah, it fires, and then we tell the patient to follow that, and then that is how we're doing our surgery.
I think the denominator is all
I think it's
outpatient settings.
all, yeah.
That's usually you do include all.
And that's always frustrating. Well, I'm speaking on the primary care side. Like, they were doing so well, and they went to the dentist, and it's, it's like, so I like that, as long as there's a way to redirect and kind of ensure that that patient gets back
And
in.
I think the clinical decision tool is going to help aid also the people who don't routinely kind of do this, to help them kind of direct towards like what are the appropriate medications.
Yeah.
Right?
Dr. Assad, I have a question. Going back a few slides, the culture of safety survey, which I guess was that survey done by Gallup?
Yes.
That was part of our engagement process. The first two items on that survey on page 13 were data exchange across hospital units and shift changes. What about information sharing, real-time information sharing with the primary care physician? Hey, your patient's checked into the hospital. Is there any communication or goal to improve communication? Or maybe there's no communication and start communication from an admitted patient's attending to that patient's primary care doctor.
Yes, there's an ADT form that actually goes out to the clinic. So to the provider will get a notification your patient is admitted. And then the admitting diagnosis.
Physician or any
Only through GPS.
only if that patient sees a JPS, but there is some sort of communication.
Yes, and
real time.
yes, it is. The ADT form, actually, this is real time. It actually goes out, and there is care everywhere. So if they are within the network, there are certain other hospital networks that I think it's Baylor is definitely in it. I think THR in it. So if it is like one of these facilities, they also get the notification.
Okay, so not just JPS doctors, it
No.
would be.
Yes, you're able to see the records.
Shared across similar.
Yes,
Sometimes
ADT
the notification is very generic, like your patient has been admitted, like it's not like why or,
Do you
And I
ever get a
would-
phone call
yeah,
from a hospitalist to talk about a patient? Never?
never.
Is that
I mean, occasionally an ER doc will call and be like, hey, I have your patient here. I think they're okay for discharge home. Can you get them in the next few days? I get those phone
you
calls.
get those?
not for every.
Now, I'm not a JPS physician, so maybe it happens a lot more
Yes,
in JPS.
not for every patient, but definitely, and what I've seen
really
working
hard
at
to do.
other hospitals also, when there is something which is very significant, then yes, the team who's actually discharging will pick up the phone and at that point call. But I will say that sometimes it's also very difficult for providers to track down PCPs.
Oh, really?
Oh, gosh, yeah. They're usually,
Because they're busy, very busy also.
We'll call Dr. Holland every time the patient occurs.
And again, just for clarification, the ADT forms is within the JPS network, the notification. But as far as like all other hospital systems which are participating in that care everywhere, you're able to kind of read the notes. But there's no such notification to an out-of-network PCP.
probably in my system, and probably in y'all's system too, you use Epic Chat more than phone calls.
Yes.
Is that, yeah. So there's a way that you can like basically message through Epic about the patient. It's a much faster and more reliable way of getting in touch with someone. So we do a lot of that, and it sounds like
We use a lot in our network, in Basket, Epic Secure Chat.
It seems like we have these data silos, which is kind of what we're getting at here with items 1 and 2. But another data silo is the patient's longtime primary care physician and then the hospital, and they don't seem to talk sometimes. I'm not talking about JPS, but all hospitals.
I think that is definitely a struggle. And I think it is very difficult to probably every time communicate, but I absolutely agree that if there is some significant change in the care of the patient or some significant things that have happened, say there is a cancer diagnosis or some significant change in medication, I think the discharging physician should pick up the phone. And most of our physicians do that.
They do.
But if there is a significant change, otherwise it would be very difficult. My blood sugar came out of control because I was not compliant, so they go back on the same medication to call the PCP, then that probably will not make much of a best use of time of PCP also.
One of the things that I know other systems are doing is like the TCM visits too. Are y'all working on TCM visits and getting patients to see their primary care doctor within a certain amount of time post-discharge? That's one way to attack the readmission.
We try to, I would be speaking out of line if I talk about the TCM visits, but I will say that we try to get them into PCP, especially for high-risk patients, within 7 days. And that's the group that meets almost every single day. We identify patients who are at risk, and we get them an appointment within 7 days.
Thank you.
All right. Then comes our quality dashboard, which we share every time. I will say what Dr. Bedamosi always emphasizes, that there are a lot of red, but a lot of things are heading in the right direction. The biggest thing I will say is that this year and kind of these things started last year, what we want to shift towards is when we see a pressure ulcer, it's too late to see it. When we see a line infection, it's too late to see it. I think you have to do something before that. And I think there's a lot of proactive things that are being put into place at this point, where there is we have created a tool at this point, which is live, where we are trying to track, okay, this catheter was in the patient for how long? The central line was in the patient for how long? Was the skin actually looked at? Where there is a lot of proactive approach so that these events ultimately get minimized. So instead of going into all of these things, I will say a lot of these measures, because of proactive approach, will continue to get better. I will highlight one thing, that when you look at the serious safety event, it may not be a bad thing that our current score is going up, because I think it also speaks to the fact that we are feeling more and more comfortable with reporting.
What is the failure to rescue? What is that metric? It's under the CMS mortality.
Say it one more time.
She's asking about failure to rescue.
Failure to rescue.
Failure to rescue is what?
It's under the CMS mortality.
Mm-hmm.
The definition.
Yes, it is basically, for failure to rescue means that if there is a complication that happens, and you could actually, if you had intervened, you could prevent death. Did you intervene to prevent that? For example, if there was post-op hemorrhage, did you do the right things to prevent that? If there was post-op sepsis or some kind of an infection, were you able to do the things to prevent death? It's a tough measure. Post-op respiratory failure is another.
I hadn't seen it on this before, yeah. So.
Dr. B keeps up to speed with
Oh,
all the
God.
metrics
These are
and
new.
tracks them. And I assure you, he has an action plan for each
Like
one
an
of them.
EMS
I may not even know all the action plans which he does. All right. Okay. Next is our copy presentations. This quarter, we had about 8 presentations, and I will just walk you through the amazing work that our teams are doing. ED, I know Dr. Kirby is going to be very excited. Our ED is the 13th busiest ED in the entire nation, which is not a surprise. And I will say what I am most proud of is, Dr. Kirby, we get trauma level 1 certification, we get MLOC level 4 designation, we get comprehensive stroke designation, but you guys are truly the entry point and the gatekeeper. If our ED was not as amazing as it is, I don't think we would be where we are. And next, a couple of other slides will highlight that. Okay. This is, I know it's a busy slide and written a little small. I will highlight on the extreme right, fiscal year 25, we saw about 138,000 patients, and you can see how we pan out as compared to the other facilities. However, we are operationally very nimble. If you look at this slide, if you look at Houston Methodist, their ratio of visits per bed is about 54. Look at us at number 3. We have 582 beds with visits per bed standing at 233. This just speaks to the operational nimbleness we have.
What are we doing wrong in North Texas? Man, Parkland and JPS.
Very busy. These are the metrics which we track and trend. Median boarding time, we stand at 232 minutes. The benchmark is about 252 minutes. All comers included, the ones that are admitted and not admitted, stands at about 7 hours. I will say, I know that everyone who works in this hospital knows that there is a lot of emphasis which is put on throughput. We have a daily throughput meeting, which is definitely happens once a day, but about 50% of times happens about twice a day. We discuss each and every patient. We look at who's medically cleared, how they can be moved, and why is this extremely important? Because if we are able to vacate beds in the hospital, that allows our ED to be decompressed. Also, we have a monthly meeting, which is all ED-based, which looks at all the ED metrics, the response time of consultants. So I think between these two, we are able to keep a very close watch on the median boarding time. In spite of being so busy, I will also highlight our left without being seen stands at a 1.8%, which is extremely impressive, and our goal is about 3%. Door to EKG time, less than 10 minutes, is about 100%. And then our patient experience, Dr. Duncan often reminds me that many years ago it used to be in single digits. We stand at a 64.7%. Extremely impressive.
Dr. Assad, can you explain item 3, ED door to EKG STEMI? What is the significance of that? What does it mean in layman's terms? And why is that one of the metrics you're showing here?
I am going to probably let Dr. Kirby speak about it, who's an ED physician.
That sounds good.
Whenever patients present to the emergency department and there's any chance they have a heart attack that could go straight to the cath lab, the metric is that they get an EKG within 2 minutes. So any treatment could be a heart attack, severe dyspnea, severe hypertension, chest pain, they will get an EKG within 10 minutes, 100% of the time.
Wow. And then this median boarding time, what does that mean?
Median boarding time is, so you look at the 232 minutes, it's basically when the patient has an admission order in, from the time the admission order goes in by the admitting provider, how long does it take for the patient to be moved to a floor? Meaning like med-surg or progressive care unit. The reason why this is so important is ED does best what is needed to be done in an emergency setting. The inpatient or the hospital doctors do best for patients once they're getting admitted. It's all about providing the right care in the right setting. We want the patients to be moved out of the situation where people are best at treating emergency situations and not after. So hence it's tracked.
And so there's an opportunity for improvement. What is the ED admitted patients, approximately 7 hours?
Yes, that is basically all comers. It is the one that are admitted and the ones that are not admitted. So every person that walks through the ED is not admitted. But the length of stay for all the patients combined, which is those that are admitted and move on to a floor, plus those that come to the ED and then get discharged, that is about 7 hours. Stay in the ED. We want to minimize that.
And that says opportunity for improvement, so we're not at 7 hours right now, I guess. We're higher than 7 hours.
No, it's basically saying it is standing at about 7 hours, so basically that's an opportunity for us.
And we want to make that lower than 7?
We would like to make it.
Do we track the wait time from walk in the door till you get called back?
Yes. We track each and every step from the time it is actually, remember the meeting I said there's a monthly meeting which happens purely for ED. It tracks like the time it takes for from the entry to the first scene, how long does it take for the doctor to see the patient. All of these metrics are actually tracked.
And is that data here in this presentation? Like the
Yes, the ED has a lot of metrics which we follow, but we are more than happy to bring it next time.
Okay. Well, one thing I'd be interested in seeing is time from walking the door till you're first called back. What do you call that metric?
I don't know exactly what it's called, but we track it.
Well, a national benchmark that we follow is door to provider time, and a good number is 30 minutes. And
Ours is 20 minutes.
20 minutes.
We are very good.
As busy as we are now.
yes, it averages out to be less than 3.
Yeah, that'd be good to have on our metrics
Okay.
for future meetings.
Let me just make a note so I don't forget.
Well, since I don't know what I will tell you, one of the ways that we do so on that metric is we don't wait for the patient to come back. So if we have 70 beds and 50 of them have admit holds, our physicians are actually going into the waiting room and seeing patients earlier, and that counts as starting of care because we've been seen by the physician. And it's not necessarily in a room, it's wherever they're at, we go to them and
Right.
we get the care started.
That's great.
They are amazing.
We have a good support team to help with that.
All right. All right, let's go on to utilization management. Extremely important. We are very fortunate. We have our own physician advisor, which is Dr. Robert Peeler. It's extremely important to have a very robust utilization management services because you want to make sure that the patients who are admitted are actually compliant with the rules and regulations of CMS. You want to make sure that the status under which a patient is admitted is actually accurate, and that involves a lot of provider education. We, as I said, are very fortunate. We have our own physician advisor. And I also want to mention over here is that our rate of success with denials is about 70%. Okay. All right. Every time a patient gets admitted, we have to submit clinicals to the insurance companies. Our clinicals, and that accuracy is very important. We stand at 100%. Also, we want to make sure that our team, so the utilization management team is not just the physician advisor, there's also like a lot of UR nurses. We want to make sure that we have an inter-rater reliability going on, so we actually do a quality audit score, and our score is 100%. Our biggest challenge is with the Medicare Advantage plans. With Medicare, it's pretty simple. They follow the 2 midnight rule. The Medicare Advantage companies, Medicare Advantage insurances, they do not like to follow the 2 midnight rule. The role of the physician advisor and the UR team is to make sure that they work with the rev cycle, the CDI team, and hold them to that standard, that they also have to comply with the 2 midnight rule as long as the severity of illness and the medical necessity is met. So we are very good with making sure that if they don't comply, then we file complaints with CMS.
Dr. Assad, before you move on,
Yes.
let's go back to the last chart. I don't see left without being seen, left after triage, before treatment, and then left against medical advice. Is there something that we track there?
Which one? Left without being seen without?
But left without being seen, and left after triage but before treatment, and then left, and then the other one could be.
We can bring that data because I'm hearing Dr. Kirby is saying yes, that we track it, so we can definitely bring that. So what you want to see is that after the triage happens, is there a data that patients leave?
But they leave it and left against medical advice, right?
Left medical advice, we actually do track.
Okay.
That's not very high, it's actually low.
Because those are good indicators to see where we are outside of the clinical environment also as well.
Yeah, we track that daily, and we fraction out who left without being seen, who left before treatment, who left AMA, and every day we look at them.
As AMA, we track every day.
Coming back here, but at least if it's out of range, then alert us or something like that.
Yes.
You guys tracking?
Yeah,
And it's
it would,
normal, just leave it alone, but.
yeah, if we started to see that we had concerns about it, then it kind of hits these kind of, right, report outs to the board at that point, that there's opportunity.
Okay. All right.
On the utilization management, have you all noticed that there's an increase in the denials coming through? Yeah, I've heard it's just a trend as
been
insurance
going on
just
for a
denies
long time.
everything.
That's your Medicare.
And that's why I think having a very strong physician advisory program is critical.
It's a lot of work.
When you're saying that Medicare Advantage is not following the 2 midnight rule, how are they not following it?
Definitely not as a blanket statement, but they will try to push the boundaries. How they're not, they're basically going to deny the stay.
Are they saying that the patient
Doesn't,
should have been there more than in 2 days or wasn't really there? What do they say?
Sometimes so basically for a 2 midnight rule, it is from the time that the care starts, whether it is in the ED or anywhere, that is where the clock should start. Sometimes they'll say, okay, but you actually switched the patient to inpatient, but then the patient ended up only staying like a day or so. So there's a lot of disagreement in as to where the 2 midnight really actually started.
But the net result is they're trying to underpay.
Yes.
Okay.
They want to pay it as just an obs.
As an observation, okay.
Do we need to be concerned about the 72-hour rules for a patient?
72 hour. 72 hour.
Like, when you're in an ED, there's a 72-hour rules that will, if you admit them and all that stuff. Is there a reason?
72. The social holds. So the problem with this, so we're going to the ED. We're talking about the 72-hour social hold in the ED.
ED transfer to to be admitted type thing? You have to look back.
Right. So
That could be some of the cost for Medicare Advantage, denial, and stuff like that too.
the 72R, I will just explain what the 72R ED social hold is, if that's the question. So the 72R ED social hold is there is a very few, maybe 1 or 2 patients, maybe 3 in a week where we decide that this patient we are not going to get admitted. Why? Because there is no reason, no severity of illness, no medical necessity for a patient to be admitted in the hospital. It's actually called a social hold. And at that point, no one wants to take the patient, and if you end up admitting the patient, A, they really don't qualify for an admission. They don't qualify for an OBS, they don't qualify based on severity of illness or medical necessity. Ultimately, their dispositions become very difficult. So the reason we do the 72-hour wait in the ED, again, these are very few patients. The reason it is done is so that every effort can be made with the family, with the facility that may have sent the patient here, with the case management for disposition, because once they get admitted, it's extremely difficult to, for disposition of these patients who do not have a medical reason to be admitted, either as OBS or inpatient. Insurance would not pay. These are social. There's no reason to be admitted in the hospital. Good discussion. We'll go on to the lab. Very proud of our lab. A lot of accreditations which we get, we may not see lab like as the reason, but the reality is that they play a huge part. We were just CAP certified, and this is not the first time, and we have done an amazing job with that. We have we have hematology, chemistry, pathology. They support our antimicrobial stewardship, which is a chapter in Joint Commission. Our great cancer program with all their requirements and their designation with the Cancer Center, American College of Surgeons. They significantly help us with that. And I know we brought the lung cancer program, all the genetic testing, they make it happen. They help us with the prior authorizations.
So this slide here on laboratory, that's a shout out for ProCraft, I guess, and the work.
And our lab.
And our lab.
Yes. Too. Yes. It's so in our NQSC, which is the Network Quality Safety Council, these are committees. So it's not the ProPath. They have a separate presentation to NQSC, but this speaks of our full lab, which is our employees and ProPath. Just like for the ED, it is IES and our entire other JPS ED team. Lab, they have great turnaround time, as you can see, with the metabolic panel and the complete blood count. Their call-in time for the critical values is amazing, which is extremely important. I will highlight the number 3, which is the routine biopsy 2 business days turnaround time is at 54.48. At first glance, it looks like it's not doing very well, but it's not that they're not doing very well, it's the data capture. At this point, they include the turnaround time should exclude, but does not exclude all the special stains and where you require decal for like bone infections. Hence, this data is not as clean as it will become with the Beaker implementation in April.
Can you adjust it?
Yes, it will be adjusted in April.
Does it take longer times?
It will be adjusted in April because it will remove the cases which require special stain or add-ons and decal. Environment of care and life safety, extremely critical to our existence. They basically have a full oversight of our physical environment and continuous regulatory readiness when it comes to the CMS and Joint Commission standards. The thing is that there is really no internal benchmarking for it, but we have created some internal rigorous standards so that we are not really kind of confined by the external mandates. The important thing, obviously, with the aging facility, the building, is that we have to prioritize our workflow based on the location and the needs. What do we measure? They're doing very well, actually, on most of their metrics. I will highlight that there's a lot of education and training going on to make sure that the staff has the knowledge for evacuation action plan. And the other thing I will highlight is when you look at the percentage of the environment of care work orders, which were completed within 36 hours, it stands at 45%, right? Yes, it looks 45%. And it is because of the aging facility, the infrastructure, but also remember that the volumes with this aging facility of these call orders is pretty significant, and also the turnaround time for the contractors and vendors. So what can we do about it? Till we get a new building, be proactive in rounding, making sure that the things are identified till they become a problem. That's our biggest, and then prioritization. Medication management was another group that presented. Extremely important when it comes to making sure that in whichever way we are using our medication is a standardized way, and we can reduce medication errors, and we are in compliance with the CMS and Joint Commission standards. I will share with you, we are doing very well with titration. I remember a few years ago when this used to be a problem, and we received some great accolades even when Joint Commission came with our titration protocols. So that's a huge win for us. And they're doing very well on all their other metrics. We have a very good medication management committee. Respiratory care, they're across the network, inpatient, outpatient. They do our ventilator management. They are the ones responsible for pulmonary function test, ABGs, and they work in also very high acuity areas, our ICU. Dr. Bedamosi is working with them. Their metrics are going to look very different because they're doing very well on their current metrics, and we don't want to just keep the same metrics on which we are doing very well. Unplanned extubations, we are standing at 0.56. Last year it was like 0.85, I think. Yes, 0.85. So doing hugely better on that. Average days per ventilator, given how sick our patients are, being at 2.87 is remarkable. Our goal was 4.22. And then you can also see our third next available for PFT and EMG is pretty good also.
Just as an example of this, I mean, they're doing well on all of their metrics. How often are respiratory care expected to change their metrics and goals so that they're focusing on other things or not?
They present twice to the Network Quality and Safety Committee, and if they're doing, I mean, I've seen that they've done very well on this metrics. This is their second time. So if you're really very stable, about 6 months to 1 year, time to really. And that doesn't mean they go away. You can keep them as tier 2 metrics, as Dr. Bedamosi has pointed out. They have to stay.
Are each, is each group coming up with their own metrics, or are sometimes you and Dr. Bedamosi saying, I want y'all to look at this? How are y'all
At the end of the day, we want to make sure that whatever metric any area actually chooses has to be in alignment with what the network is trying to do, making sure that it has leapfrog, CMS, whatever regulatory other standards are, it is. So yes, they are the experts in the area. We expect them to come up with suggestions, but at the same time, we also need to make sure that we have some say in it.
Can you explain why it's days to third next appointment on those last two metrics? What is the significance of the third next appointment?
I am not a person on the ambulatory side which can explain that metric very well. I may like to lean on Dr. Duncan because I've heard her explain the third next available.
Are you asking in particular about third
Just
next?
third
or
next.
Why we're following that?
Yeah, I didn't know what that meant and why we're following it.
Yeah, so we followed it across almost all of our ambulatory areas. How quickly can we get somebody in that needs either a procedure or a visit? And so that's kind of national standard is, how long does it take? Actually, it's the way, you probably can do it better than I am.
And it probably talks about the health of the organization, because if there's a cancellation and you get an appointment is not a good measure. That's why you want to look at like third and next available.
Next day, because if somebody cancels today and I call, I may get in now. But you want to get on average, how long does it take for someone to be able to get into an appointment?
So it's not by chance. We want to make sure your system is actually hardwired, that you're not just getting appointments because someone canceled or something happened and you were able to get that.
That's an industry standard.
It's an industry standard.
It is for primary care, should be like 24, we got 22, you know, we below national average, but for specialty, it's about 35 plus day. So this is kind of general, so we can't tell if it's specialist or primary care physician.
Yeah, it does give you an indication sometimes that you're now, that you have more people that are entering into a
35
system.
plus day for national average.
Yeah, if it goes up, it may indicate, Blake, if it goes up, it may indicate that you've got more people coming into the system and you may need to hire an additional dermatologist or
Okay.
a cardiologist because you're seeing it's taking longer and longer for people to get into the system. So it does give the organization an indication of how much need you need from a provider.
Okay, good. I didn't know that was a standard, so makes sense.
OR. This committee actually oversees the perioperative strategy, surgical workflow, multidisciplinary stakeholders to resolve the system barriers are part of this committee. Every metric is tracked. We've created a dashboard with a metric from the time you actually put a case request to the time actually the surgery is completed. And without a surprise, we all know surgical volumes have continued to increase. This year, much higher surgical volumes than last year. And obviously, yes, a proactive approach to all surgical safety events. Like ED, this also has a very robust dashboard, but we only brought here very few metrics. And one of the feedback which we gave the team was that we track a lot more. So starting next time, we're going to bring more metrics. But again, we can see the total case volume year over year, the volume has remained high. On-time starts, we are doing very well. Benchmark is about 66%. We are at 70%. Turnover time at 30 minutes. Outpatient surgery on the day, same day cancellation is about 7%. Target is less than 10%. And immediate use team sterilization is very low. It's 0.29%. And the goal is improvement over self. Behavioral health. We have behavioral health delivering care, inpatient setting, outpatient setting, and we have our very unique model of the Psych Emergency Center, which has gained a lot of recognition. They are doing very well on all their metrics. I will highlight one key area over here, the restraints and seclusion hours per 1,000 patient bed days. While we are doing very well, I will just highlight here that sometimes there are about 1 or 2 patients, like they've said there were 2 patients who total about 63% of seclusion minutes in October, and then there was 1 person who actually accounted for 75% of the seclusion minutes in the month of November. So sometimes, even though we are doing very well, we actually probably are doing even better than that, except that there are some outliers. Because this is extremely important and high-risk area, we want to make sure it's an ironclad action plan. So team huddles, if there is events, there are 2 events, there is a team huddle. If there are 3 events, there is a medical review. And then there is obviously escalation to a multidisciplinary level also.
I was just looking at their metric is that, the tobacco, alcohol, and substance use intervention at discharge. And they're achieving target there. And then earlier, that's one of the metrics that we're having to work on. Is there something that they're doing particularly well and how they're integrating it into the discharge that could be maybe used in the other areas that we're not meeting target on that?
Good question.
Yep.
They're better at asking the questions.
It's a good observation. Use best practices.
They might be able to advise. All right. Any questions for Dr. Assad? Thank you. That was exhaustive, and we appreciate it. I don't think we have anything that needs approval today, so we will go ahead and, can we close? Do we have anything in closed?
Yes.
Okay, so we'll go ahead and close the open session. I can get a sniff.
We've already pulled together the commands.
Oh, wow.
She was saying use our new housing,
Yeah,
Thrive
like the
on
Thrive on
Crawford.
Crawford.
They're only 80% filled. Maybe
Yeah,
we
there's a
send
couple.
over residents to go
Yeah,
stay
that means
over
there's
there.
about 15 rooms.
Yeah,
Yeah.
yeah.
They're not rooms.
Those are nice rooms.
All right, so we will go ahead and close this Quality and Patient Safety Committee meeting. Thank you all for attending. We good? We out?
You have to hit the hammer.
Huh?
Did you gavel? There you go.
It's official. I didn't gavel in. I consciously didn't do
Well,
it.
then the meeting
so-
doesn't